Next talk is the outcomes of carotid endarterectomy and carotid artery stenting in functionally dependent and independent patients by Dr. Ahsan out of Penn State in Hershey.
Hi, everyone. Good morning. My name is Ahsan Zil-E-Ali, and I'm a research fellow from the Division of Vascular Surgery at Penn State College of Medicine. And the paper which I'm presenting is titled as Outcomes of Carotid Endarterectomy and Carotid Artery Stenting in Functionally Dependent and Independent Patients. Before I go further, I would like to share that the authors of this work declare that they have no conflict of interest. By the already known information, we know that in 2001, Institute of Medicine report emphasized the importance of preoperative functional status assessment that can help us achieve optimal quality of care. Since then, there have been multiple studies for various different surgical procedures suggesting that how functional status can help us predict outcomes. Keeping in mind this, we further looked into the literature and we learned that it is known that patients with declining functional status precedes the cardiovascular-related hospitalizations. Furthermore, evidence also suggests that functional status can be a predictor in perioperative outcomes of arterial revascularization and carotid endarterectomy. Keeping in mind this background knowledge, me and my co-authors designed a research question which is precisely as, what are the outcomes of functionally dependent and independent patients undergoing carotid endarterectomy or carotid artery stenting? To answer this question, we looked into the data source of American College of Surgeons National Surgical Quality Improvement Program NSQIP database, which is risk-adjusted, a validated data source which collects information from more than 700 centers across the country. Furthermore, to capture highest number of patients in the both pools of endarterectomy and artery stenting, we studied from 2011 till 2018. We further subgrouped our population into functionally dependent and independent patients. We followed the definition of these both subgroup populations as available in the NSQIP dictionary, which is that functionally dependent patients are the ones who require assistance, whereas functionally independent are the ones who do not require assistance. Although there is a third category as well in the dictionary, which is partially dependent patients, and we merge that with the functionally dependent patients category in order to achieve better subgrouping to further have more convenient analysis and better understanding. We defined our primary outcomes to be 30 days mortality and 30 days stroke, whereas our secondary outcomes were pneumonia, unplanned reoperation, intraoperative time, length of stay, and prolonged hospital stay, which is beyond 30 days. We use chi-square test for categorical variables analysis, and for predictive modeling, we use multivariate logistic regression model for analyzing the outcomes. First, we looked into the demography, and we saw that there was a statistically significant difference in gender, age, race, BMI, and ASA classification in the patients undergoing carotid endarterectomy. Although we only found ASA classification to be significant in carotid artery stenting. If we generally look into the pool of the patients, we saw that there were 26,043 patients in carotid endarterectomy pool, with the functionally dependent patients only 718. Whereas in carotid artery stenting, we found 1,114 patients as a whole, with the functionally dependent patients only 46. We stepped further to look into the postoperative outcomes, and we learned that 30 days mortality was statistically significant in the patients who are undergoing carotid endarterectomy. And we also saw that unplanned reoperation still in hospital beyond 30 days was also statistically significant among patients who were functionally dependent and independent. Pneumonia and length of stay was found to be statistically significant for the both groups in carotid endarterectomy and carotid artery stenting. In general, when I'm saying statistically significant, I mean that there is a statistical difference of the patient populations that fall in all these categories. Lastly, in this analysis, we found that stroke was insignificant in the both populations. Then we looked into the regression analysis for carotid endarterectomy outcomes, And on the right side, the image can show that 30 days mortality analysis showed that there were 3 times higher odds of mortality in the patients who were dependent versus the independent patients. Whereas we saw that length of intraoperative time was 36% higher in dependent patients as compared to independent patients. Our other secondary outcomes, including unplanned reoperation, pneumonia, length of stay, and stay in hospital beyond 30 days, were having higher odds as compared to the independent patients. Henceforth, according to this analysis, we learned that there were overall poor outcomes in dependent patients, in secondary outcomes, and also in the primary outcome of 30 days mortality. In regression analysis for carotid artery stenting, we found that pneumonia and length of stay in hospital were having higher odds in the dependent patients. Although the pneumonia had a very broad confidence interval, and hence drawing a precise conclusion is not possible from this data. In the third analysis from the regression modeling, we did a comparison of functionally dependent carotid artery stenting patients versus the functionally dependent carotid endarterectomy patients. And we learned that there was a 3 times higher odds of stroke in dependent patients when treated by carotid artery stenting, and there were lesser intraoperative time in the carotid artery stenting patients as compared to endarterectomy patients. Lastly, we did a 30-day survival estimate by using Kaplan-Meier and time series analysis, and we learned that carotid endarterectomy survival among the dependent patients was 97.35, whereas higher in independent patients, that is 99.34, with a survival difference of 1.99. In carotid artery stenting survival, we learned that dependent patients had lesser survival, which is 95.65%, as compared to the independent patients undergoing carotid artery stenting, which is 98.51. This survival difference was much higher than the survival difference of the patients in endarterectomy pool, with 2.86%. On the right side, the image can show that the red line on the top, which is functional status independent patients undergoing carotid endarterectomy, had better survival as compared to functionally dependent patients undergoing carotid artery stenting on the last line. So according to this all analysis, we conclude that functionally dependent patients undergoing carotid endarterectomy and artery stenting have poor outcomes. Henceforth, we can say that the functional status is a predictor of deciding the outcomes. Preoperative functional status is of paramount importance in guiding the outcomes of both procedures, and it is important to give the due importance to the functional status assessment prior to signing off the surgery for any of these 2 procedures. Lastly, we have the limitations from the study, and one of the big limitations is that we use the NSQIP database, which is not giving us the data beyond 30 days. A missing long-term follow-up data is one of the limitations of our study, and also there are fairly less number of patients in carotid artery stenting pool. Therefore, it's very difficult to draw precise information. This brings the end to my presentation. Thank you very much, and I would like to answer if somebody has any queries. Again, thank you very much.
Great presentation. I'm going to start with the first question, and there are already a few that are popping up. Basically, this question is not meant to be combative, but I I was listening to the presentation, reading the abstract. My first obvious thought is, we do carotid endarterectomy or carotid interventions to prevent stroke, to prevent being functionally dependent. And if you're already starting with a patient population that is functionally dependent, in my mind, the role for carotid intervention would seem very, very small for this patient population. So, is it really something that we should be performing in these functionally dependent patients? Should they really just go on, maximum medical therapy? And I guess it also depends on which are symptomatic versus asymptomatic. Your thoughts on that? You're muted.
Yeah, thank you very much for your question. So this is from out of the scope of this presentation, but further for the manuscript, we also did matching between symptomatic and asymptomatic, seeing various different demography, and we will be presenting that in form of a manuscript. Yes, we did it, and that is the further analysis coming from this paper. That which we did is more towards the quotient exact matching, which we used, and we didn't present that in this presentation.
What about the first part of my question about doing carotid interventions on functionally dependent patients? I mean, do you think we would derive a clinical benefit on those patients?
Yeah. So the thing is, the main concept is from this study, we are seeing how it is presenting as a predictor. This is the main idea. Whether it is a predictor or not, yes, eventually we have to provide the care. And I believe that more work can be done and to learn more about it.
Okay, Jeff Syracuse sent in a question. Did you use targeted data sets? I don't really have any clarification if he wants to put in one for that.
I think the targeted one is related to the only vascular PUF files, if he means this.
Okay, maybe he'll offer a clarification. Gabriela Velasquez, how did you define those patients that were partially dependent? Did you use some sort of ADL scoring to separate the different groups?
So the partially dependent ones are is a third category, and that was the one which we combined. There are three categories in NSQIP, and my PI would like to answer a question.
Dr. Lowe, can you hear me?
Yes.
All right. Hi. Good morning, everybody. I'm sorry. I'm trying to log into a different computer. I agree with you. I agree with you completely. I think that is the question we were trying to answer. Should the functionally dependent patients be touched at all? And this is a retrospective study of all the, across the country from NSQIP. Needless to say, I mean, it tells us what is happening across the country. And one take-home message from this is absolutely that asymptomatic patients who are functionally dependent should not be offered a carotid intervention, number one. Number two, the dependent patients in this cohort included partially dependent and completely dependent. So there is a little bit of a gray zone there. And number three, I think somebody asked a question. Yes, it was a targeted database. As you guys know, that NSQIP has two, one big, huge file, and then NSQIP targeted. So the two files were merged based on the NSQIP targeted file.
Okay, thank you, Faisal. Excellent. I think along that same vein, Gabriela Velasquez also wants to know, did you consider using the VQI? And I think we had touched on in previous talk about some of the limitations of the VQI data set, but did you consider using that as an alternative?
Yes, that is. As you know, the VQI needs submission approval for the proposal. So yes, after this analysis, our next step is in fact to request VQI for their data and compare their outcomes as well.
Okay. I think, and then Jeff Syracuse added another thought, and I agree. I think having some more details about the symptoms of the presentations would be helpful too, because I think we would all agree that the different symptomatic symptoms don't all necessarily correlate to the same outcomes.
Absolutely. So if you look at NSQIP database, the symptomatic status is a binary variable. I'd say yes or no. As you mentioned, somebody coming with emesis fugax versus dysarthria, completely different clinical pictures. But we're limited in this study by the NSQIP pre-populated variables, which basically say, a yes or no.
Excellent. I think those are all the questions. Thank you so much for the presentation. Good job.
Sounds good.